All right, welcome to the third annual MS and Vision event of Seeing the World More Clearly. Tonight we have Dr. Williams and Dr. Narayan with us, and my name is Claire Clements. I'm the Director of Development. Tonight's going to be a panel discussion, and it's led by Mr. Horace Derricott. And Mr. Derricott's going to ask the panelists a bunch of different questions that are very common, questions for MS and vision. We encourage you all to participate. If you have any questions regarding anything that the panelists say or your own questions, please let us know. Write them down on the note cards. We'll come by and pick them up. Again, tonight we're filming, so just be aware of that. Try and keep down the noise. I know you guys are a pretty rowdy group. Housekeeping, please help yourself for any more food if you need it. And also the restrooms are straight through the double doors by the exit sign and take a left. So I will hand this off to Horace.
All right, thank you. Welcome everybody once again. Before we get started with our questions, I want to take an opportunity to introduce our two panelists. I'll start with Dr. Williams. Dr. Mitzi Jo Williams is a neurologist and MS specialist at the Multiple Sclerosis Center of Atlanta. She earned her BS degree in neuroscience and behavioral biology from Emory University, and her Doctor of Medicine from Morehouse School of Medicine in Atlanta as well. She is certified by the American Board of Psychiatry and Neurology and holds memberships in the American Academy of Neurology and the Consortium of Multiple Sclerosis Centers. She serves as a board member and member of the Clinical Advisory Committee for the Georgia chapter of the National MS Society. She is also a clinical advisor for the Multiple Sclerosis Foundation. And secondly, I'll start with Dr. Kannan Narayan. Dr. Narayan joined the Emory Eye Center on July 1st, 2015 as an assistant professor in the neuro-ophthalmology service. Dr. Narayan has a primary practice at Emory Hospital Midtown. Dr. Narayan is also an academician, and he has co-authored 15 peer-reviewed articles and 4 book chapters. So let's take a second and welcome our two guests. So, are you ready?
Let's go.
Let's go.
Okay. I promise there won't be any trick questions. So the first one will go to Dr. Williams. Dr. Williams, please provide us with a little background on MS and vision. Why does MS affect vision?
Absolutely. That's a great question, and I'm so glad all of you came out tonight. I'm excited to see you all and talk a little bit about multiple sclerosis. So vision is a very common issue with multiple sclerosis. We're going to talk mostly about optic neuritis, but that's not the only symptom that can occur with MS. MS is a autoimmune disease that affects the central nervous system, which includes the brain, the spinal cord, and the optic nerves. So what happens is that the immune system, the part of the body that normally attacks viruses and bacteria, gets confused and attacks a good part of the body. The part of the body that's attacked, or the substance that's attacked, is myelin, which is the coating of the nerves. And when that myelin is attacked, it causes inflammation and swelling and sometimes severe damage. And that's what results in the symptoms that we see. One of the more common places that's affected is, as I said, the optic nerves, which are part of the central nervous system. So when the optic nerves are affected by inflammation and attack of the immune system, that is what we call optic neuritis. And that can result in a variety of symptoms, including blurred vision, sometimes decreased vision, sometimes loss of vision. People can also have decreased color vision, and then they often will have pain with movement of the eye. So those are very typical symptoms of optic neuritis. Sometimes they all occur together. Sometimes it can kind of progress over several hours to several days, and it's because of that attack of the immune system on the optic nerves.
Okay, thank you. The next question, Dr. Narayan. How common is optic neuritis or optic neuropathy, and does it get worse over time?
I think good evening to everyone. So we need to differentiate the two words, optic neuritis and neuropathy. Neuropathy is a much broader term that's referring to any type of problem in the optic nerve. And optic neuritis is inflammation, as we know, appendicitis, tonsillitis, very similarly. There is inflammation of the nerve, and so when you think of the inflammation, there is pain and pain on eye movements. So that's a very characteristic feature, and there can be central vision loss. So there's two things. So in terms of the frequency, overall, if you compare to diseases like diabetes or heart disease, these are rare conditions. But optic neuritis and multiple sclerosis can be quite common and quite frequent. In different series, if you look at, you get varying incidences between 15% to 45%. It might be more with one of the cousins of MS called the Devick's disease or neuromyelitis optica. Optic neuropathies in general, which is more common, and we are learning more about these with one of the newer modalities of diagnosis called optical coherence tomography. So we see a lot of optic neuropathy in MS patients, even in those who have not had a prior optic neuritis. So I think that the numbers and the statistics are changing, and we're learning a lot of more new information.
Okay, thank you. Now this question is for both of the doctors. Can you speak on the difference between using oral steroids to treat optic neuritis or steroids being used through an IV? It is said that oral steroids work, but they will cause optic neuritis to return or come back.
I guess so I can start.
Sure, go ahead.
Give my short answer before
Please.
expound. So, the typical treatment for optic neuritis is corticosteroids, which are steroid medications. Sometimes they're given in the IV. Sometimes they're given by mouth. It's also the treatment we use for most symptoms of relapse of MS, which optic neuritis is considered in many cases a relapse of MS. So in the optic neuritis treatment trial, which is a pretty large trial looking at treatment of steroids versus IV steroids versus oral steroids versus placebo, which is no medication, what they found was that both IV and oral steroids did help speed up the recovery of symptoms, but in the people who were on oral steroids, it seemed like they had a recurrent attack more quickly than those who were who had IV steroids. So I think generally many people treat with IV steroids for optic neuritis for that reason.
Right. Yeah. I think those are great points. So this study had roughly about 500 plus patients nationwide, and it was basically for optic neuritis, not necessarily with MS. And with the IV steroids, they figured out that the ones who got the IV steroids, the onset of multiple sclerosis was postponed by about 2 years. So that's another advantage of the IV steroids. And with the oral steroids, as is already discussed, there might be more recurrences. But if somebody has a very minimal visual symptom and the vision loss is not great, it is perfectly okay based on the trial not to treat them in terms of, because the final outcome at about 16 weeks was the same. The speed of recovery was different if you're treated or not treated. So if somebody is not treated for any reason, if it is typical optic neuritis, it may not make too much of difference, especially if it's a very mild vision loss.
Absolutely, and I think that goes for many symptoms of MS. And the reason that we know symptoms get better is because many times people will have symptoms and not go to the doctor, and the symptoms will go away on their own. So the goal of steroids, whether they're IV or oral, is to try to speed up the body's ability to recover, but they do not necessarily make you overshoot the point that you will recover to, just for most symptoms, including optic neuritis.
Okay, thanks. The next question, Dr. Narayan, what is the difference between NAION and optic neuritis?
Okay. So NAION, it stands for, these are just complicated terms, in medicine, basically non-arteritic ischemic, anterior ischemic optic neuropathy. So the optic nerve is actually a long structure, which is about 5 centimeters. So inside the eye, we only see 1 millimeter of it. But the rest 49 millimeters is behind the eye. And so there are circulation issues that can affect the optic nerve. So let's say somebody is 48-year-old and diabetes, they have diabetes and hypertension, and they can have an acute vision loss that is related to the nerve. It can be either an optic neuritis or it can be a blood circulation issue, which is called the NAION or non-arteritic. So it's basically, lots of eye doctors use the word stroke for this, it's called an eye stroke. It's in reality not similar to a stroke, meaning that it doesn't lead to a stroke or anything, but it is the circulation issue within the nerve. And these are very small twigs of nerve that supplies the front part of the nerve, the blood vessels, and they get blocked. And the risk factors include the vascular risk factors of diabetes, high blood pressure, smoking, sleep apnea, some of these symptoms. It is not a progressive disease in terms of like optic neuritis or recurring disease. It's usually a one-time vascular event, and the treatment of steroids is not a standard of care in that condition. So it is it becomes important to differentiate the two. This becomes important in that age group of patients between, let's say, 40 years and 55 years with other risk factors as we discussed.
Okay, thank you. Dr. Williams, please explain Udall's phenomenon and how patients can prevent or deal with it.
So Utah's phenomenon is a really complicated way of saying or talking about the effect of heat on MS, right? So everybody knows we had a brutal summer this summer, right? Yes, you can. Okay, yes, okay, all right. I know they're taping, but you can still be interactive. Okay, so we had a really brutal summer. So the interesting thing is that all of my patients that have been coming in the past couple of weeks have been like, Dr. Williams, the summer was horrible, my symptoms were horrible, okay? It's a very common phenomenon with MS. And basically, heat, whether it is physical heat in terms of going to the beach and laying out in the sun, whether it is your body becoming overheated, for instance, like if you do a workout or a very brisk run, or even if your body becomes overheated in terms of you have a fever or some type of infection. Basically what it does is it takes those nerves that have been damaged by the immune system, and when you heat up those nerves, the signals are slowed down even more, right? So if you already have signals that are running slowly because they've been damaged and maybe cause a little bit of tingling, let's say in a leg, if you heat them up and the signals slow down even more, then the tingling will become more pronounced. So many people say when they're out in the heat or when it's hot that their symptoms feel worse, and usually when you go and cool down, the symptoms will improve, right? And I usually tell everybody when I do these programs that back in the day, before we had MRIs, doctors used to do a hot bath test to diagnose MS, right? They put you in a hot bath and you were weak when you got out, you had MS, right? Because we know that heat makes it worse, right? Now, obviously, we don't put everybody in a bath nowadays, but if you walk outside in July, that's basically the same thing as getting in a hot bath. So it's a very common phenomenon. I think one of the important things to recognize is that heat-induced worsening is what we call a pseudo-relapse, okay? So it is not a true relapse in the sense of you have new lesions in your brain or spine that are making you worse. It is a temporary worsening due to some inciting or event that caused it to worsen. And usually once that event or infection or what have you is removed, your symptoms will go back to baseline. So we generally do not treat those episodes with steroids because they will get better on their own after the infection is cleared up, after you get some rest, after you get out of the heat.
Okay, thank you. Dr. Narayan, are there other eye problems that occur with MS patients besides optic neuritis?
Yeah, so apart from optic nerve, you can obviously have lesions in the brain in the area that controls the eye movements as well. So, see, if you have problems there, so the two optic nerves go back and meet at a point, and then they go backwards, and actually the vision happens in all the way in the back, what is called the occipital lobe. So you can have different types of problems which manifest in the visual field test that may not be optic neuritis alone. This is called the afferent system, which is the circuitry that takes the message from outside inwards. There is another circuitry in the brain that controls the way the two eyes work coordinated. So if you look sideways, up and down, or tilt your head, so there is a complicated circuitry, and there are 6 muscles for each eye that control these pathways. And you can imagine that if those circuitries are hit, the vision in each eye is fine, but people can develop double vision, or people can have involuntary eye movements where the eye shakes in different directions called nystagmus. So one can develop other problems. So the commonest problems seen in MS patients, one of them is called INO, or internuclear ophthalmoplegia, can be seen. And the other one is the nystagmus. So probably those are, it's called the pendular nystagmus, acquired pendular nystagmus. In fact, that can be a presenting manifestation in an adult where somebody who's fine starts suddenly seeing that things are shaky when they look in particular directions or looking straight ahead. And so a nystagmus or shakiness of that kind of nature always calls for an MRI in an adult patient.
Okay. A follow-up question for you, Dr. Narayan. Is there a way to repair the optic nerve once it's been damaged?
We wish. Yeah, there is a lot of research, and I think one of the recent trials on antilingo, they are trying to see. So we have learned a lot with the newer techniques, as I mentioned, called the OCT. We do know that a lot of changes happen in the first few weeks, and the damage as well as the repair is complete by about 6 months. And it is also postulated that probably within the first few hours the changes start, and so what we call as the neuroprotection, do something very quickly. There is a lot of interest, and people are looking at different chemicals in different parts, including the eye chambers, trying those fluids and other things, including the blood. But I don't think we have a very good way of repair at this time in terms of treatment.
Yeah, not yet. So there was some work is some work that was done with a chemical called antilingo to try to remyelinate or repair the myelin. And it was a very small trial that showed that people who took that chemical, their optic neuritis seemed to improve. They seemed to have more improvement in their optic neuritis if they were younger, and the optic neuritis was caught earlier. But unfortunately, in the larger trial that was recently done, the phase 2, it did not show positive results, meaning it did not show that it really helped with remyelination as we would have hoped. There is another chemical that's in earlier stages, I think the first phase of research, also looking at remyelination by a different mechanism, but we've not really heard any results of that one yet.
Okay. Let's, for both doctors, what is the best thing you can do for yourself as an MS patient with vision issues?
I'll start. Okay.
Okay.
So the best thing you can do for yourself, so I think it's very important, or I'm a big advocate of people being their own advocate and educating themselves, not necessarily with Dr. Google. I'm not a big fan of Dr. Google, but certainly coming to programs like this, learning about different things that are going on in research, talking to your doctor about new advances. Those things are very important. I think in terms of visual difficulties, obviously, as we said, we don't yet have anything that fixes what's already broken. So our goal with most treatments is to try to prevent new things from being broken. So one of the best things that you can do is speak with your doctor, whatever treatment you all decide on for MS, to be compliant with that and to stick with that. And if you're having problems, then your doctor knows that it's because the treatment is not working and not because you're not taking it. And obviously, if you have problems with the treatment, it's important to go back and talk to your doctor and make sure that that's the right treatment for you. So I think being consistent with whatever treatment plan you and your doctor decide on, doing those follow-ups, your doctor will probably get MRIs at certain intervals, making sure you do that, and then making sure that you revisit if this is the right medication for you, and certainly if you have any symptoms, letting them know so that they can reassess and see if the treatment plan needs to be changed.
I think that's excellent. I think I would just add, as we were talking about Uthoff's phenomenon, right? Even with the optic neuritis history, you can have the same phenomena happen with the vision also. So somebody will start noticing some visual changes and think they're having optic neuritis again. It might just be the same phenomena. So getting good exercise and getting hydration, probably I would just add those to it.
Absolutely.
Okay, and the last question for this part is there any new research going on regarding optic neuritis and optic neuropathy?
So I don't know of a lot of research going on with optic neuritis. I know that the original optic neuritis treatment trial, they continue to follow people over time and kind of present more results over time.
Right, so that trial, I think they presented the 15-year data, and that's finalized. But otherwise, with optic neuropathies, there are a lot of new trials that are going on. There is a trial in Wills Eye Hospital relating to ischemic optic neuropathy that we talked about. There is no treatment for that condition at this point in time. Similarly, other optic neuropathies, one of them is called hereditary optic neuropathy. It's called Leber's hereditary optic neuropathy, which has got nothing to do with MS, but it's a type of optic neuropathy where people can go blind in both the eyes, and it is because of a genetic type of condition. And there is a new clinical trial that's going on where there is a single mutation. So they are injecting into the eye and trying to see, so that's the phase 2 trial that's going on at this time with the Liebers. So there is work going on, but we still don't have too many promising results.
Hello, my name is Patrina Pryor, and I just had a question about, are you saying that once you have optic neuritis, you will always have it? Is that true, or?
No, optic neuritis is an acute inflammation at that point in time, so it heals very well.
Okay. I asked that because in '97, that was my first episode, and I haven't had any episode. My situation is very, very different. My last episode was in '07, and that was just nerves in my legs. Since then, I have had no symptoms, so I hate to say it like this, but I'm kind of like waiting, or not waiting, but I'm, just wondering what, if I'm going to have another episode, because I was diagnosed with it. I am not on medication, but I still, have some concern, so.
I would say, I think there are like less than 5% of patients with MS. There are different types of prognosis. You can talk more on that part in MS in general, but there is 5% who are so lucky that they might have 1 or 2 episodes like you said, and then they may never get again, which is great. So optic neuritis with MS in general, the body does extremely well. That's why I was saying even with the steroids, if it is very mild, you don't necessarily need to treat it because it almost always heals. There are studies that have shown, however, that even though it is healed well, the MRI shows everything is fine, the patient doesn't have much symptoms right away, they feel that it is improved, but some patients notice the quality changes afterwards between the two eyes. For example, when you are playing tennis, the way the ball is coming, this eye is perceiving a little faster than the other eye, so there might be little depth perception issues, and moving objects may look a little different because the two eyes are, so there are tiny bit of quality issues that might come up, but that's not an ongoing optic neuritis issue, but it is because of the change that already happened, those kind of things. But usually optic neuritis is very well.
Okay.
Good evening. And first of all, one observation or statement and then 2 questions, if I may. The observation is that we're all very blessed that you guys are here for us this evening and that you have dedicated so much time of your life in your studies and in your work to help people who are, patients of or dealing with MS. So thank you, number 1. Number 2 is kind of related to that is, what caused your interest in this field of medicine? And then the second question is there any research that shows links between optic neuritis and just general things in life like stress or anything like that might be a cause of the onset of that?
So I guess I'll start. In terms of interest in the field, I am a people person. And I'm the type of person who kind of goes into a situation and it either feels like home or it doesn't. And so I was fortunate enough to do one of my first neurology rotations as a resident with Dr. Mary Hughes, who was my mentor and who's the director of the MS clinic at the Medical College in Georgia, Medical College of Georgia. And I just fell in love with the subject. I love the patients. I like developing relationships with people. And so that's why I chose MS. In terms of a link between optic neuritis and stress, in MS in general, many people, there have been many reports, I would say, of people having stressful periods before starting to have symptoms of MS, some of them kind of psychological stress, some of them physical stress in terms of like car accidents or some type of trauma. There have been many articles that have tried to address that, but as far as I know, there's not been a direct link between physical or emotional trauma and multiple sclerosis. It is pretty common that when people have traumatic experience, sometimes their symptoms will temporarily worsen. As of right now, we still kind of categorize that in the pseudo-relapse period. But I think the honest answer is we probably don't know everything that causes the start of it, but as of right now, from the literature and the research that's been done, we can't make a direct link to say someone getting in a car accident causes their MS, or someone having a traumatic experience causes their MS, because many people will develop it out of the blue, right? Nothing's going on and they just wake up and they can't see out of one eye. So it's a very difficult question that's been asked, and I think that people are looking at it, but I think that we really don't know as of right now.
Yeah, very briefly, I did ophthalmology training, and when I was doing that, I did see lots of complicated cases which were always related to neurology. So when I had an opportunity to do the residency in the US, I did neurology training. So I do neuro-ophthalmology, that's the interest. And in terms of the stress, I would be very general. She already answered about the MS part. I would say it's known in the autoimmune world, in autoimmune diseases in particular, like they tend to be associated, the flares may be associated with stress. So MS being at least considered autoimmune to the majority of the extent, I would think that there would be link. But again, from a scientific standpoint, there are very particular ways of studying, and that's not been proven to that extent. But I would think it would not be a surprise if it comes out to be a major factor, actually.
When do you know you need to go see the ophthalmologist versus going to see the neuro-ophthalmologist? And what has to happen with your vision? Do you know you go this way first or go that way first? And the other issue is it, I have issues where I went blind in one eye, did steroid treatments, and then a couple years later, I went blind. Had issues with my next eye. So I'm just like, is it more inflammation or something, nerves that move from one eye to the other eye?
Okay. So first question, when do you see who? I think if the symptoms are milder forms, like little irritation in the eye, little blurriness of vision, that's slow, like it's been there for 3 weeks, 3 months and not changing much, it's always a good idea to start from an ophthalmologist or an optometrist, and when they examine, if they do the visual field, if there is anything in particular that they are concerned, then they could make that call to refer to a neuro-ophthalmologist, etc. But if it is an acute loss of vision or acute symptoms, meaning that things that come on very quickly, in a patient who is known with MS, the ideal is probably neuro-ophthalmologists are in general, like the number of neuro-ophthalmologists is very small. In the US, there are only about 550 neuro-ophthalmologists. So it's very hard, as you can imagine, it's hard to find someone to see somebody very quickly. But the most important with any of the MS flares, if they're suspected, whether it's optic neuritis or otherwise, even if it's a double vision or nystagmus question, the treatment, the first thing needed is an imaging, and the second thing is an IV steroid. So both of them can be done through hospital admissions. So if it's an acute problems, that would be the thing to do. And the last thing was about your particular case. It's very hard, as you know, because of HIPAA, to make specific comments. But I would say that if it is a severe vision loss, we use the word atypical optic neuritis or neuropathies. And one of them, we talked very briefly, one of them is called DeVick's disease or neuromyelitis optica. That should be tested for. And it's very commonly recommended that it should be tested for these days, even for the first episode, because the treatment is different for the condition. And it is a very tough disease in terms of the devastating complications and it can lead to.
So the DeVick's disease, the treatment for the vision problem is not steroid?
It is steroids, but it can be followed by other treatment options such as plasma exchange.
Yeah, the treatment for the disease itself is different than the treatments for MS.
For the acute part, it is IV steroids still.
Okay, that was a perfect segue because we are all here. We all have neuromyelitis optica, DeVick's, and I started as an MS patient. I first had optic neuritis, lost my vision, then they go in my left eye, came back after a couple months after IV steroids, and was treated as an MS patient for 11 years. On the third time that I have optic neuritis in the same eye, and each time, as you said, it comes back after a few months. The third time, I just thought, okay, I'm going to lose my vision in 2 days, and I'm just going to go get some IV steroids, and it's going to come back in a couple of months. Only the third time it didn't. And that vision loss was different. It left really quickly, but it was like fireworks. And it never did come back. And that was when they discovered that I really didn't have MS, that they had the tests now, and they changed all my treatments to the NMO treatment. So my first question is, because they're different, the two diseases are different, then is the optic neuritis different? Therefore, what you just said, the treatment is different. And would you say for an acute person, so I'm blind in this eye now, so if something happens over here, my neurologist has suggested plasmapheresis versus like an IV steroids. Can you talk about plasmapheresis? Is there any other, if you know someone obviously has not good luck with optic neuritis, what would you say would be like a Hail Mary, like if I were to go blind in this eye?
I'll start. So obviously, again, we can't give specific medical advices for people, for people's conditions, but kind of generally. So for those of you who may not know what DeVick's disease, so neuromyelitis optica or DeVick's disease, I consider it kind of like a cousin of MS. So it is also an autoimmune disorder. It also affects the myelin, but it generally affects the optic nerves and the spinal cord predominantly. So people present with a transverse myelitis, which is a lesion in the spinal cord that can cause weakness or numbness throughout the extremities, or they can present with optic neuritis or both. Sometimes people can have lesions in the brain, but they're not typical of what we see with MS. Okay, the lesions are a little bit different. So it used to be considered a part of MS, like a kind of subcategory of MS, but more recently, as they developed the antibody, the aquaporin 4 antibody, it now is considered its own separate disease, and the treatments are a little bit different. So with optic neuritis, or with relapses in general with DeVick's disease, they can tend to be more severe in some cases than what we see with MS. So we still use corticosteroids if people are responsive to them, but sometimes we also use plasmapheresis or plasma exchange. I kind of consider it's kind of like dialysis, but not dialysis. And so basically what they do is try to kind of cleanse the blood and wash the antibodies out of the blood. And sometimes that does cause improvement of symptoms, but steroids are still used, but sometimes that's considered a second line. If someone has not been responsive to steroids, sometimes within the same relapse, sometimes in a subsequent relapse. So sometimes if someone has like a bad transverse myelitis and we give steroids and it doesn't get better, then we might go to plasma exchange. Or sometimes if they had a relapse and the steroids took a long time with the next one, we might go straight to plasma exchange. That often is done in the hospital. It can be done as an outpatient, but generally it's done in the hospital, and that's usually done for about 5 days, either 3 or 5 consecutive days.
What about stem cell transplants? Have that ever been used as a treatment? And also, does optic neuritis, have you known it to affect hearing?
No, so optic neuritis does not affect hearing, right? There's two totally different things.
Those two are different things.
Yeah, two totally different things. In terms of stem cell transplants, much of the research with stem cell has been done more in MS. NMO or DeVick's disease we're hearing more and more about it, but it is not very common. So it's very difficult to even get enough people to get into a research trial. So for instance, there was a medication there was a medication that was being tested for DeVick's disease, but it was very hard to enroll people in the trial because they didn't want people who had been on certain medications, and most of our DeVick's patients had been on those medications. So it's really hard to find enough people to enroll in clinical trials. There has been a lot of research done with stem cell with multiple sclerosis. And there have been I've seen a lot of kind of misleading titles of articles saying that doctors in Canada have found the cure for MS with stem cells, right? So we have to be kind of careful with that kind of language. Basically what stem cell is kind of a resetting of the immune system. So what we do is we take some of your baby cells out, okay? We clean those up. We wipe out what's already there with chemotherapy, okay? And then we give you the baby cells back and hope that they do not eventually develop into MS cells again. And I'm really, really simplifying it. So there have been several studies looking at stem cell, and the research has been going on for years. So the research in stem cell transplant has been going on for 30 years. Most of it in Europe. We're now doing more in the U.S. And from the studies that have been done, a significant number of people, probably 50 to 60% of the folks in some of those trials, did not have any further symptoms of MS, okay, relapses or worsening on MRI. But certainly that did leave a significant number that did, okay? And then the other issue becomes, once you have that type of rigorous treatment, it can put you at risk for side effects with many of our other medications. So it kind of leaves doctors in a quandary of what do we put you on now if you failed that very extreme treatment, okay? So there is a lot of research being done. There's some academic centers across the country that are doing a lot of good research. Obviously, they're doing research in Canada, research in Europe. So there's a lot of promising research, but it has a long way to go, okay? There's a lot being done, but we still have a long way to go to kind of figure out where that fits into our treatment armamentarium or our treatment regimens.
Yeah, two very quick comments. One is that you can do IV steroids and combination of plasma exchange right after that. That would be the thing. And with the NMO, there are newer medication. One of them is the Rituxan. I just want to mention the name. With the stem cells, we got to be very aware of the scams that are there, in different parts of the world. So, as of now, as far as I know, I don't think stem cell is proven treatment, except for maybe in some leukemias.
Yes.
Apart from that, there is no stem cell treatment for any other condition that's proven, at least the ones that we are discussing. So if anybody, this is the kind of thing, there is a lot of, if you Google, you can find 100 centers all over the world doing these kind of things, and the people have spent, raised money from the community and gone out there.
GoFundMe
and,
accounts, Yeah, and I think it's important to distinguish that the stem cell transplants that are done in the research are bone marrow stem cell transplants, okay? Many of the centers that have popped up around the country do fat stem cell transplants, okay? Or adipose is fat, okay? Which is totally not the same thing. So I have had several people, unfortunately, who have gone to these places and paid large amounts of cash to have fat stem cell transplants. So that is not what we're talking about in the research studies. We're talking about bone marrow stem cell transplants, not fat stem cell transplants. Great questions.
Yes, have a few from the guests. If someone has both MS and diabetes, will that develop into optic neuritis?
The diabetes doesn't necessarily add to the optic neuritis part, but one can get an optic neuropathy, not necessarily directly related to diabetes, but it can be the ischemic optic neuropathy that we talked about earlier. So depending on the age of the patient, sometimes it might be hard, but pain is an important differentiating feature. So in classic optic neuritis, there should be pain. If there is no pain, the other diagnosis should be considered.
Okay. Is MS hereditary?
Great question. So MS is not what we would consider a directly inherited disease, okay? There are several factors that play into the cause of MS. One of them is genetics, okay? If you have a first-degree relative with MS, the risk for developing MS is increased, but it's still very small. And genetics is not the whole story. So for instance, with a disease like sickle cell, if mom has a gene, dad has a gene, we can predict 1 in 4 of the kids will have the disease, okay? With MS, there are over 170 different genes in different combinations, okay, that are associated with increased risk. And even with those genes, we really don't know exactly kind of what they do in terms of causing MS. I do have some families, or many of us who treat MS, there are some families where multiple people have MS or multiple people have autoimmune diseases. Somebody will have lupus, somebody will have MS, somebody will have rheumatoid arthritis. But I have just as many, if not more, where that person is the only person, right? So because it is not currently considered directly inherited, when someone's diagnosed and they come in the office, I say, okay, now, don't go get MRIs on all the kids and all the brothers and sisters, okay? Don't line everybody up for MRI, okay? Certainly if someone has symptoms, They should be evaluated, okay, because they have a family history of MS, but we don't go recommend looking for things that we don't know what to do with, okay? So the answer is no, it is not considered hereditary in the direct sense, but certainly genetics can play a part in increasing the risk for MS.
Okay, thanks. Next question, is different sized pupils normal for a person who has nerve damage from optic neuritis?
Different size pupils? No. So pupils react differently if somebody had an optic neuritis, which is in the medical terms called RAPD, relative afferent pupillary defect. Previously they used to use the word Marcus Gunn pupil. But the size should be the same because the nerve that controls the size is different. It's the third nerve, and the one that causes the vision part is the second nerve, which is the optic nerve. So the size should not be different. But when it comes to the difference in size between the pupils, about 15% of normal population can have differences in size between the two pupils. So definitely if anybody is found to have a new change in the pupil size, it needs a neurologist evaluation.
Okay. The next question, not sure if we need additional parts on this. Is the eye really damaged or is it just inflamed?
In optic neuritis, you mean? Well, eye is not damaged as such. We talked about the nerve. Nerve is a structure that starts from the eye. There's only a small part into the eye, and the nerve is inflamed, and it can lead to varying degrees of damage. Most commonly, it recovers very well.
Okay. Dr. Narayan, this was addressed to you. You mentioned IV steroids postponed the onset of MS. How did that manifest itself?
This was in one of the large trials, and the onset in those patients was later. You mean, I don't think in terms of specific manifestations?
Yes, that was me. You didn't give specifics, and so I was like, is that just because you're treating the eye, or is it?
Yeah, you're treating the eye, and in those patients, they did develop, but in that group of patients, it developed later. So they gave that benefit to the steroid, IV steroid.
Right.
Yeah, if you think about it, does it make all sense? Because you're giving 3 days of IV steroids and it's going to postpone something. I really don't know the answer to that question, but that's what they found in the trial. That's how it was analyzed.
I think generally steroids are not thought overall to affect the disease process, right? So generally, so for many years, so I kind of think of it in terms of, MS is a disease that's been around since the 1800s, right? 1868, the first case of MS was really described by Dr. Charcot. We did not have any approved treatments for MS until the 1990s, until 1993. Okay, steroids have been around for years before that. So many people were getting treated with steroids after steroids after steroids, and it really doesn't affect the course of the disease, right? So I think maybe in that specific case it seemed to delay, but overall it doesn't seem to have an effect on the overall immune process. So it's considered a symptomatic treatment to speed up recovery, but again, does it delay the onset of MS? I think that most of us would say.
Yeah, so from a scientific standpoint, I would say this was not something that they were trying to study,
Right.
Okay? So some things like they come, it's like a bonus, like you got it, and they just put it out there as a data.
Yeah.
It's very difficult to say, that that's not the primary endpoint, and it was not designed to study that.
Right.
So it's very difficult to interpret this kind of data.
But it was an observation in that.
That's the
particular
observation,
study.
and that it's a very large study. So, and it was prospective,
Yeah.
and they have like 15-year data. So it's a pretty good study from that standpoint.
Yeah.
Okay, another question you had on the back. Is vertigo a result of the damage from optic neuritis? Is that the question?
Not really, not from the optic neuritis.
No.
We will talk about some shaking and.
The nystagmus, yeah. So you can have vertigo from MS itself in different parts of the balance regions, like, yeah.
Have you researched anything on the, or do you use the 4AP or Ampera for any of your patients to help with the optic neuritis?
So I'll speak to it from an MS. So 4-AP or 4-aminopyridine or Ampera is a trade name for that chemical. Has been used symptomatically in MS for years, okay, for many different things. People just use it kind of as an additional therapy to see if it helps. So I've had a lot of people who were on 4-AP before it was approved as a medication. But the specific indication for Ampera is for improving walking speed, okay? So for that particular drug, the indication is obviously you have to be able to walk a certain distance, at least 25 feet. It has to be measured when you go to the doctor's office before you start, and it's approved for improving walking speed. So that particular drug is not used for optic neuritis. I've not used it in the past for optic, but maybe.
No, I have not used it, but I think there are a few neurological drugs. One of them is Dilantin that people have tried. Ampera is the other one. There are different medications that people are trying, but there are no definitive data that's available that's published.
Because I've read a couple of studies about it and kind of, I think I've benefited from it myself. So I was just curious. I also had a question about when you've got the damage to the optic nerve. I've noticed that since that happened with me, if I'm out in strong sunlight or the sunlight's coming from a certain angle, like in the fall and in the winter, that I almost lose all vision as long as that situation is in effect. Is that optic neuritis?
Yeah, it could be the effect of the optic neuritis in terms of the way that that eye is conducting as we talk. So there might be a different the way it's perceived between the two eyes. I think it can be exaggerated in varying light illumination environments. Do that.
Okay, so first of all, I just want to say my name is Laverne Crowder, and I'm the founder of the Optic Neuritis Foundation. I want to say thank you so much for thinking it not robbery of your time and efforts of coming out and speaking to the group. We truly appreciate you and what you bring to the table and educating us, and I thank you, thank you, thank you. Secondly, I want to say thank you to all of you that came out to our third annual event. It gets better each time. I hope that when you leave this event, you leave empowered and a little bit more informed than you did when you came in. So I thank you for that. All right, well, thank you so much for coming out, and we really appreciate you guys. You have the reps here, our sponsors, our drug reps here, so if you have any questions for them, please stop and talk to them. Our panelists, please, if you have any more questions, talk to them, but we thank you so much for coming out, for seeing the world more clearly. Thank you.